This is Chapter 18, Impact of Cognitive or Sensory Impairment on the Child and Family. So what is cognitive impairment? Well, we used to use the term mentally retarded. That is really not a term that's used anymore. Now we're using intellectual disability or cognitive impairment. And really this is defined by having an IQ below 70 to 75. If you remember IQ exams, the norm is 100 and a standard deviation is 15. So this means you're more than one standard deviation below the average. And this has to start before 18 years old and include, we want with these kids to focus on their strengths, to really identify what they can do and their weaknesses, and then work on ways to overcome those. So look at their functioning level, not just their IQ test scores. So to be considered cognitively impaired, you have to have at least 2 deficits out of these 10 adaptive areas: communication, home living, community use, leisure, being able to fill up your time, health and safety, taking care of yourself, self-care skills, social skills, functional academics. That means being able to buy groceries, do the math to give money and receive change, things like that. Work and self-direction. So early signs of cognitive impairment, these are kids who don't really respond to contact, voice, or movement. So you do something to them and they don't react. They're usually very irritable. They're often difficult to feed, poor or slow feeders. Poor eye contact during feeding is typical, and they just have less spontaneous movement and activity than other kids. So nursing care of these children, we're looking for delayed milestones, that they've missed those milestones, which means we've got to do regular developmental assessments on every child that we're seeing. We want to get them into early intervention programs. The earlier we start treatment, the better the outcomes. We want to teach self-care skills. We want to promote their development and play and exercise. We want to expose these kids to as many sights, sounds, and sensations as possible. And things like Special Olympics are great for that. In our area, we have Break the Barriers, which is a gymnastics area that mixes kids with special needs and regular kids and does some pretty high-level gymnastics and incorporates special needs kids into that. So nursing care of kids with cognitive impairment continued. Communication is a big problem. Their verbal skills are usually more delayed than their physical skills. So helping them to communicate, whether that's teaching them some basic signing or making some picture boards, things like that. Discipline. These kids need discipline and they're hard to discipline. So it's got to begin early. You don't want to wait because behavioral problems are common. They need limits. Certain things are not allowed. You cannot hit your brother. You cannot throw your food. So there needs to be limits. But we need to also teach them what we do want them to do. Just like with toddlers, if you say, don't do that, they're not sure what they should do. You have to give them what they should do instead. So teach them the behaviors we want them doing, and behavior modification plans where we set up something where you do this, this happens. If you do what we want you to do, this appropriate behavior, then this benefit to you happens. So when they're young, those need to be picture board kind of things. So, you have to eat in order to watch some TV. And if you don't eat or you throw your food, you don't get the TV. So that sort of thing. Socialization. Again, teaching acceptable behaviors because they don't just automatically know what those are. And as these kids get older and enter adolescence, that can be a really difficult time. You got to think about things like contraceptive use. Often kids with mild to moderate cognitive impairment have a real lack of normal filters, and being sexually active can be very common. So care for these children during hospitalization. Don't ignore or isolate them. Even if they're difficult or have odd behaviors, they need interaction. So get the parents to participate in planning the child's care. The parent knows what works for this child much better than we do. Encourage the parents to stay if they can, but don't make them feel like it's their responsibility to take care of this child. So let them know that we're there to help, but the child's used to them and knows them better. These children can be lonely. These children can be lonely, so make sure we bring in toys and activities. When we talk to them, we have to use short, simple explanations. They don't understand abstract, vague ideas. So tell them exactly what's going to happen in short and simple words. And the earlier intervention we begin, the better. And here's some other kids. So Down syndrome. This is also called trisomy 21 because it's an extra chromosome in number 21. That's almost always the cause of it. Occasionally there's a translocation, which is like swapping one of the legs, or mosaicism means not every cell is the same. So they have some cells with the trisomy and some that don't. And that's a really minimal number of these kids. So the risk goes up as a woman ages. Once a woman's over 35 and particularly over 40, the risk goes up. However, not that many women over 35 or over 40 are having children, and lots of women under that age are having children. So the majority of Down syndrome children are born to women under 35. But if you look at how many per 1,000 live births, well, it's very few, but just there's a lot more births in that age group of women. And here's an adorable little girl. So what do you see on Down syndrome? Well, we're going to do chromosomal analysis and find that trisomy. But they have a typical look to them. The eyes, they have that outward slant of the eyes. The nose is really small with a depressed bridge. The ears are small and very low set. The mouth is small and the tongue is big, so they tend to have their mouth open all the time. Their hands are broad but short. Their fingers are very short. They have a single crease across their palm, where you probably have 2 or 3. They just have a single one. And then in general, they're short in stature, but they're extremely flexible. They are kind of double jointed at all their joints and kind of floppy. They have decreased muscle tone, hypotonia. So some associated things that go with this are heart defects. A lot of our kids with Down syndrome have heart defects, especially defects to the septum. So ASD, VSD, or the canal defects are really common. They have a higher incidence of renal disorders, Hirschsprung's disease. If you remember, that's a section of colon with no peristalsis, and it has to be surgically taken out. Higher incidence of tracheoesophageal fistula. That's a connection between the trachea and the esophagus. It's an emergency. They can't be fed after birth with that. Again, requires surgery. They tend to have an altered immune system and get sick more easily, and they're at higher risk for developing leukemia. And I like this picture because it really shows modeling of the skin, if you notice that. So, Fragile X syndrome. This is our most common genetic cause of cognitive impairment after Down syndrome. This is an X-linked genetic mutation, but it doesn't follow that classic X-linked recessive pattern. So the abnormal gene is on the long end of the X chromosome. So we see this in adult men. They have this long face, prominent jaw, big ears, large testes. How it looks in children or women, most women are carriers, it varies, but it's got this typical look by the time you get to an adult male. And the problem with this is they tend to have cognitive impairments, can be anywhere from mild to severe, but they have behavioral issues, violent temper outbursts, they have delayed speech and language, they tend to be hyperactive, they tend to be hypersensitive. This is similar to autism. Sounds, touch, they're hypersensitive to that. So they do have these autistic-like behaviors that include the hypersensitivity, and they're very intolerant to change in their routine. So if you suddenly make them switch from doing one thing to another, they get all flustered and don't like that at all. So how do we treat this? Well, serotonin agents for some behavioral control, because we said behavior is a problem. Stimulants for the hyperactivity, like we're doing with ADHD. There are some newer treatments they're looking at, protein replacement and gene therapies, but really we want to diagnose this early and get these kids into early intervention programs because they really need behavioral therapy because they do have such difficulty with their behavior. So moving on to hearing impairments, we can have different causes for this, like just an anatomical problem. If you've ever seen somebody who's born without an ear, low birth weight, our preemies often have hearing issues. Ototoxic drugs, kids that we've treated with ototoxic drugs can have hearing issues. Most common cause, chronic ear infections. Can happen from perinatal asphyxia, so our babies who don't get oxygen at birth, or have infections at the time of birth, or just goes along with cerebral palsy. So the pathology of hearing impairment, we have several different types. Conductive happens in the middle ear, and if you remember, that's where those bones are that are supposed to vibrate, right? This is our most common type, and it comes from recurrent otitis media. You should have air in that middle ear, and it fills up with fluid if it's serous, or it can be pus if it's, a purulent thing. But either way, it interferes with that vibration of the bones in the middle ear, and so a child's not hearing normally, makes them not able to speak normally either. They don't learn normal speech. So how we're going to treat that is antibiotics for the infection, or perhaps ear tubes to try and break that cycle of ear infections. Sensory neurohearing loss. This means it's in that inner ear, in the cochlea, where there's little hairs that turn that vibration to nerve impulses. So this can happen from congenital defect, kernicterus, which, if you remember, that's from high bilirubin, not treated in a newborn, where it crosses into the brain. Infection can cause this, ototoxic drugs can cause this, or just excessive noise that damages those hairs in the cochlea, or mixed, where it's a combination of the two. And then central auditory imperception. These are kids who have nothing wrong with the ears, but the brain does not register sound or understand, use, and process the sound.